Our next speaker is Kristiina Kahur, the CEO of Nordic Casemix Centre. Oh, hi, Kristiina. How are you? Yeah, our steps are over here, which means our poor presenters have to do a very long walk across. So, sorry, Kristiina. Okay.
Hi, good morning, and thank you for this introduction. And thank you also for the invitation to be here, to present here. I was here in last time in Dublin, actually, in TCSI conference, which took place very close here. So this is my second time on Dublin and on Ireland. But yeah, my background is medical doctor, so I perhaps will provide some clinical insights. But as you know, ABF is more complex. It's not only clinical, or it's not only costing and funding. It's a complex system. So today I will give you, or I was asked actually to present something related to ABF and productivity. And I will provide two country examples, Finland and Estonia. Why these countries? First, I have been working with these countries. I originally come from Estonia, so I worked there in Estonian Health Insurance Fund. And also I've worked in Finland for many years. Plus, I know the language, so for me it's easier to get the information in native language instead of using Google Translator to get this information. And Nordic is kind of common or system which are used in both countries, and that's why I start actually from this. I am aware of the timing, and I will be rushed through my slides probably, and I skipped some, but I assume they will be shared later so you can get into more details. So this is just to show where the Nordic DRC system and your system is, just to see how this the evolution of the DRC systems have been happened, and the Nordic system is very much or close to this HIKVA original system, whereas your system, based on Australian system, has gone through different adaptations and modifications. So Nordic cooperation, we can call it this way. This is it started already around the Casemix. It started in the beginning of 90s, and it was institutionalized in 1995 in Sweden, in Uppsala University. And a year later, this very first version of Nordic system was then published. Nordic Casemix Centre, and this is where I'm working, and I'm representing this organization. It was established in 2008. It is based in Helsinki, in Finland, and it is owned. The system is owned by 5 public institutions from Nordic countries: Finland, Sweden, Denmark, Iceland, and Norway. And there are 2 affiliated users, Estonia and Latvia, who are also part of this Nordic cooperation. Now, there are a lot of national differences, and I will go through this very quickly. First, so just to, perhaps it might be confusing, so we talk about Nordic system, but within this system we have national modifications. So we have Nordic Finnish version, Nordic Swedish version, etc. And this is number of DRGs within these national versions, and you see the Swedish version is a bit different because they also include primary healthcare DRGs in the system. Most of the rules and DRGs are common to all versions, but then there are national differences which are adapted and adjusted into the system. There are also differences in primary classifications. All countries are using ICD-10, but then the national modifications. And again, you can see Sweden has much more national modifications than other countries. And the procedure classification, we call it NCSP, which is the UNESCO classification of surgical procedures. This is used only in these countries, and there is also difference between the number of codes. Then complexity levels. There are 3 complexity levels: non-CC, CC, and major CC. And CC stands for complexity, comorbidity, and complications. I'm not going to explain how it works, but it's different from Australian system, where there is this diagnosis. Each diagnosis is given the complexity level, and then it is put together in the episode level, and then the score is given to this complexity. All countries are using this non-CC and CC level because this was this original HICVA system as well, but then Finland and Sweden have introduced this MCC level as well, and other countries don't use it or use it in a limited way. And this is just an example of DRGs, how they are split. They can be split into 3, but they can be split also into 2. We don't use this terminology or term as adjacent DRGs in North DRG. I know in Australian system this is a term which is used. But yeah, this is, and there is also sometimes split based on age and this complexity level. To manage all this 5 or actually 6 different versions, we use certain tools. We call it North DRG tools, starting with the communication platform so that everything is documented, that it's also a good way to track back to different changes, what have happened over 30 years. Then the definition tables, which are the core of the system, and this is usually the black box, no one knows what is in there. So in Nordic system we have all transparent and open. And then there are the tools to maintain these rules. We call it rule editor or NDMS. And then we also manage the changes in the primary classifications or basic classifications, however we can be called differently. And then we also have grouper software to group the cases. Now, closer to the ABF or using DRGs for funding, you see the national differences here. All actually should be probably DRG/ABF because we use more DRG than ABF, but I think we talk about the same thing. So you can see that all countries are using DRG some way, and this is only for inpatient settings now. But then they have complemented this with other payment methods, and depending on country, it can be really a wide range of different methods. So DRGs are important for funding and also other uses, but they obviously cannot solve all the funding issues and funding problems. So the funding model really has to be designed the way that it is efficient and also productive. Now these country examples I told you about, starting with Finnish model. And why I picked these two, they are very different, how countries are dealing with the measure productivity. So in Finland, there is Finnish Institute of Health and Welfare. In Finnish, the abbreviation is DHL, which I'm going to use here. So this is the benchmarking tool, and also benchmarking has been mentioned in many instances today here already. So to measure activities, but also cost, quality of care against national and also group standards. And the purpose is to provide comparable information. They use it only in specialized care and also to support decision making and also facilitate planning and resource allocation. And they really use it. So it's not only nice to know thing that they are published a lot of data in the website, but they really hospital manager using this information. So they use different sources. The primary data source comes from National Social and Healthcare Data Collection and Reporting System. They got Hilma in Finnish. So this contains data on patient activities, but then there are also supplementary data like cost data because they link all this patient level information with cost, and this allows them to use it for benchmarking, to measure the productivity. They also used an underlying system or platform to run all this data and produce these outputs. And they use the standardized comparison by using North DRG because this takes into account all these different complexities and age and adjust it to the case mix. And then the productivity is measured as a relationship between outputs and inputs, and this is the way how they do it. And here are some examples. I'm sorry, the graphs are in Finnish. So on the left-hand side, you can see the change starting from 2019 in university hospitals. In Finland, there are 5 university hospitals, and you can see that the productivity actually is going down. We know that 2020 was COVID and 2021 was the consequences and etc. Plus, in 2023, Finland went through a very extensive reform, and it came into effect in 2023. This is only 1 year, but actually, I think in terms of, or instead of increasing the productivity and efficiency, it seems the result is a bit different. But of course, they need a longer time frame trend to see it. And on the left-hand side, there are just grouped the hospitals into university hospitals, which is the green line and which actually reflects the same what is on the left-hand side. But then the central hospitals, the orange line, goes up, so there are differences. And this is the way how they can look at this. They also dig into the specialties, and also within the hospital they can, using same methodology, they can check the department level information and use it then for further actions and budget allocation and whatever. So there are many outputs what they can do with this data. So yeah, to conclude the Finnish part, this is really a vital tool what the manager and policymakers are using. And I remember usually they publish it in an event like this. They invite all the hospitals' representatives, and then they show. So it's very transparent. There is nothing to hide. They just show it, and then everyone can compare against the peers. Now, Estonian case is a bit different. They are using strategic purchasing, and Estonia, the health system itself, is based on social health insurance model, whereas the Finnish one is tax-based, like NHS kind of model, like yours, I assume. So it is financed through Estonian system through payroll taxes, which is paid by employers. So it's a year-mark tax. There is quite broad benefit package which is approved by the government. And it includes different services, starting from primary healthcare, but also medicines and also some in-cash benefits. And then the gatekeeping system is quite strong in Estonia. Family physicians, but even more family nurses are actually often the first access point for the patient with clinical issues, unless it is urgent and they have to go to the emergency room. So this is just and this is taken from the WHO database to show the differences between Estonia and your country, where the money comes from, and you can see the big proportion of social health insurance contributions in the Estonian case versus which is tax-based mainly. And you can see also this changes in 2020, 2021, when the government transfers were higher due to the COVID pandemic. So this Estonian Health Insurance Fund acts really as a strong purchaser organization, and they purchase the health services. They pool these funds into their budget. They run the budget around 2.4 billion per year, and then they use this budget on different health services. The vast majority goes to almost half to the hospital services, but then the other services, and including medicines, are there as well. They use robust contracting systems, so the health insurance fund enters into contracts with healthcare providers, and I will show this detailed contract template. So they really act as strategic purchasing, and through this they also push and drive this productivity. So they don't measure the productivity this way as Finland, for example, does. So what is if we compare strategic or passive purchasing, so the strategic means that it is really first, it is selective contracting. Not everyone or every hospital has to be contracted. Then the payments are made on health needs. They monitor the quality, and also the three main questions is how to pay, which are the payment methods. Is it activity-based? Is it fee-for-service? Is it other payment methods? Then from whom to pay, and this is the selective contracting. They don't contract all providers who are in the market or who have the license for provision of services. And then what to purchase, and this is this benefit package, what is included there. Versus the passive contracting, or it's not probably contracting, it is just paying the bills when they are submitted. This is evolution of the contracting control mechanism, a lot of details there, but I would like to perhaps address here that they started with very simple, unsophisticated contracts. There was gap on the contract level in the beginning of 90s when Estonia regained its independence again and got rid of this Soviet occupation. So it was, of course, very simple one, and there was no knowledge and capacity. But then they developed the contracting system. They started with hard volume caps. They separated the settings like take care, inpatient care and outpatient care, and also the specialties, just to target really the needs of population and purchase strategically the services which are needed. And later they moved to the soft caps, and they gave it's still the same at the moment, that they give the flexibility or freedom to the providers to adjust the resources or reallocate the resources within the contract. And also if they exceed this cap, then the health insurance fund is still paying, reduced price, but still paying. And the latest change was in 2014, when they, by paying more for outpatient cases, they incentivize the providers to move the services, of course, if possible, from inpatient settings to outpatient settings. And these are these motivations or incentives within the system. And this is now this contract template. There is a lot of information, but I try to just to explain very quickly. So it is divided between, or capped half year and full year. There is location, because it's very important to target the people who are living in certain geographical place. Then there are specialties, and this is in Estonian, but I assume you can read some of the specialties and understand without knowing the language. And then they have these settings divided into outpatient, daycare, and inpatient, and then they have these gaps, or volume gaps and cost gaps. So this is quite an extensive and sophisticated matrix, but this is what they are using. Now, as I said, in Estonia, DRGs are used in inpatient care and also day surgery, but it is not the only payment method. So this is just to show how their shares of different payment methods, and this is from 2019-2020. They are pretty stable. It also depends on the outliers and because the outliers are paid based on fee-for-service, but there is no 100% activity-based funding in Estonia, and the claims are paid on ongoing basis as they are submitted. This is just to mention that in one hospital in Estonia, which is located on island and which is strategically important because there are people living there, they started with ABF, but then they switched to global budget because it didn't work and doesn't work because they have to keep this. The patient volume is really fluctuating. It's also the holiday area or regions. So people go there, they have some peak seasons, and then they have very low demand. So they have to keep this hospital alive. And the government and health insurance fund, because it is strategically important. And there they use only global budget, for example. So they determine the volumes and they give the pay based on that. So there is no activity-based funding used at all. Now these contracts are based on historical data, but they also use estimated need for patients and that take into account the population changes, also the insured population, which are actually related to the labor market situation, because as I said, employers pay the social contributions, and if the labor market situation is getting weaker and unemployment rate goes up, then it also influences also the income of health insurance fund. They also do the service utilization review, predict the changes, and also take into account the changes in the benefit package. Roughly, the hospitals are divided into two in Estonia who are eligible for the contracts with the health insurance fund, and there are 20 strategic hospitals in the list, and the rest are competing for the contracts. And regardless of how they get into the contract or enter into the contract, 80% of the previous year calendar year volumes are taken also to the next year contracts, but then this 20% is negotiated and reallocated between the providers depending on their performance in the previous years. There's a set of indicators which they are using, including quality, efficiency, throughput, etc. I don't have time to go through this, but so this is much more complex than just taking historical budget and carrying it on to the next year and next year and next year. So this all is supported by digitalization, digitalized claims management. Starting from 2000, Estonia has a digital claims database, and it's also obviously plays a very crucial role also in the strategic purchasing function. And here are some just couple of examples how digital claims management is supporting the strategic purchasing, starting with just simplified submission of claims. So there is, they call it electronic channel between provider and purchaser organization, and the claims are submitted on ongoing basis. And this is also ensures the stable cash flow for the hospital, so they don't have to wait until next month's 15 day or something like this. It's ongoing basis. And this also allows to apply automated claims verifications or automated controls in this channel, so that the claims which don't meet the criteria, and these are all defined, they are rejected. Doesn't mean that they don't pay, but they are just sent back to the hospitals, and so they may correct if it is possible. So this allows also to improve the data quality and to check the data quality before the payment, so they don't need to deal with this after that. And of course, this contract template I showed you, it's very sophisticated. Obviously, it is not done in Excel or any very simple platform. So this digitalized claims database allows to also monitor and plan the contract. So it goes automatically as soon as these caps are entered into the system. And initially, when they started with, and it's of course ongoing, but when they, for example, in primary healthcare, the very initial payment method was capitation. It was flat capitation, but when they started with this digital claims system, or the claims were digitalized, and it also allowed to actually improve the capitation. So it is adjusted to the age. Also the DRG system, which was implemented in the beginning of 2000, this was thanks to the availability of digitalized claims database, which allowed also to develop and phase in the DRG system. And now they are working on the bundled and value-based healthcare or value-based payment methods. So this is something what is really facilitating, not talking about the performance monitoring and benchmarking, what this digitalized claims database allows. So final remarks. So this strategic purchasing, and you have to understand the context. I understand that this is very different from yours, and it is not probably possible to take anything perhaps or perhaps something to your context, onto your system, but still this purchasing body or purchasing function is very important, and this allows to also to drive productivity through the contracts, which are currently soft. There are soft caps which incentivize also providers themselves to optimize their performance. So there is not need to use all the money they have given in the beginning of the year, but actually they have this freedom and flexibility within their contract throughout the year, adjust and reallocate the volume so that actually the patient needs is met, not that the hospital can fill the beds what they have in their facilities or in the building. And also combining different methods, as I showed, the DRGs or ABF, fee-for-service, they have also clinical pathways, per TM rates, etc. This balance between designing the funding model is important because, as you know, different payment methods give different incentives or disincentives, and this is to motivate also the providers to provide a safe behavior to use the resources efficiently. Digital infrastructure is very important, which is supporting this strategic approach, and also the quality and geographical access. As I showed, it's also in the contract indicated, which is actually the service provision, like the location. They're currently working on more sophisticated purchasing function or strategic purchasing, and they are developing or shifting from volume-based to value-based purchasing. And as I said, they started already their initiatives to develop clinical pathways. They have started with very big ones, which are also taken in terms of resources, in terms of budget, they take a big part of the budget. So there are endoprothesis, for example, stroke patients. They go on with some mental health issues, etc. So they are continuously moving there and improving their purchasing functions. So that was it. And thank you very much.